Good morning. I'm Dr. Visheta, and today we'll discuss about the topic etiology of malocclusion. So, what is malocclusion? Malocclusion is a condition in which there is any deflection from the normal relation of the teeth in the same arch or in the opposite arch. So, etiology of malocclusion can be broadly divided into general factors and local factors. What is the need for classification? So we need classification to group all the problems, orthodontic problems, for the location of the problem that is to be treated, for the diagnosis and treatment plan, for comparison of different types of malocclusion, for self-communication, for documentation of problems, to be used for epidemiological studies, for the assessment of treatment effects of the orthodontic appliances. So there are mainly four most important classifications: Moyer's classification, White and Gardner's classification, Prophet's classification, and Graeber's classification. Moyer's divided the etiology of malocclusion into 7 categories that include heredity, developmental defects of unknown origin, trauma, which can be prenatal trauma and postnatal trauma, physical agents, which may be prenatal or postnatal, habits such as thumb sucking, tongue thrusting, lip sucking, posture, nail biting, and any other habits, diseases which include systemic diseases, endocrine diseases, and local diseases, and malnutrition. White and Gardner's classification of etiology includes 4 categories that are dental base abnormalities, pre-eruption abnormalities, post-eruption abnormalities, and abnormalities in the path of closure. Pre-eruption abnormalities include abnormalities in the position of developing tooth germ, missing teeth, any supernumerary teeth, prolonged retention of deciduous teeth, large labial frenum, and traumatic injury. Dental base abnormalities include anterior-posterior relationships, vertical malrelationships, lateral malrelationships, disproportionate size relation of teeth and basal bone, congenital abnormalities. Post-eruption abnormalities include muscular, that is active muscle force, rest position of musculature, sucking habits, and any abnormalities in the path of closure. Premature loss of deciduous teeth, extraction of permanent teeth. Abnormalities in path of closure includes any premature loss of deciduous teeth or extraction of permanent teeth. So coming to the Graeber's classification, Graeber's classification can be broadly classified into general factors and local factors. General factors include heredity, congenital defects, environment, predisposing metabolic climate and disease, dietary problems, abnormal pressure habits and functional aberrations, posture, trauma, and accidents. Local factors include anomalies in number, in tooth size, tooth shape, abnormal labial frenum, mucosal barriers, premature loss, prolonged retention of the teeth, delayed eruption of the permanent teeth, abnormal eruptive path, ankylosis, dental caries, and improper dental restorations. Coming to the general factors. General factors mainly include heredity, the first one being heredity, that is the number of human traits. There are n number of human traits that are influenced by the genes, which include tooth size, arch dimension, crowding or spacing, abnormalities in tooth shape or tooth number, overjet, interarch variation, and frenums. Local congenital defects. Congenital defects can be classified into general congenital defects and local congenital defects. Local congenital defects include clefts of face and palate, macro or microglossia, cleidocranial dysostosis. General congenital factors include malnutrition, endocrinopathies, infectious diseases, metabolic and nutritional disorders, intrauterine pressures, or any accidents that are caused during pregnancy or childbirth. Environment include various prenatal and postnatal environmental factors. The prenatal factors include disturbances in embryological development, such as neural crest cell problems, defects in formation of organs, fetal molding, teratogens, maternal infections, diet, and metabolism. Postnatal factors include forceps delivery, which might cause injury to the temporomandibular joint area, which can cause ankylosis. In such patients, there can be retarded mandibular growth, and thus that results in hypoplastic mandible. Cerebral palsy is a condition which is characterized by muscle incoordination. This may occur due to birth injuries, traumatic injuries that can cause condylar fracture, which can lead to growth retardation, which might lead to facial asymmetry. Then coming to predisposing metabolic climate and disease, which includes endocrine imbalance, such as following conditions can also cause malocclusion, such as hypothyroidism, hypoparathyroidism, hyperparathyroidism. Metabolic disturbances such as acute febrile diseases, which are believed to slow down the pace of growth and development. These conditions cause disturbances in the tooth eruption and shedding, so they increase the risk of malocclusion. Predisposing diseases such as polymyelitis. Dietary problems such as nutritional deficiencies, that is cause any disturbances in development timetable. Rickets, scurvy, beriberi can produce severe malocclusions. Premature loss of teeth and prolonged retention of deciduous teeth can also be seen. Abnormal eruptive path, poor tissue health, and decreased fluoride intake may cause loss of teeth due to caries malocclusion. Accident or trauma. Both prenatal and postnatal injuries might cause dentofacial deformity. Then coming to local factors. Local factors include anomalies in number of teeth. That is, in order to achieve proper occlusion, the number of teeth that are present should be proper. Any presence of extra teeth or absence of one or more teeth will lead to malocclusion. Heredity plays a very strong role in the anomalies in number of teeth. Now coming to supernumerary teeth. Teeth that are extra to the normal complement of teeth are considered as supernumerary teeth. These teeth may have abnormal morphology, or they may not have any abnormal morphology and resemble normal teeth. Extra teeth that resemble normal teeth are called as supplemental teeth. No definitive time when supernumerary teeth may develop. Mainly they form prior to the birth or as late as 10 to 12 years of age. Coming to the classification of supernumerary teeth, based on its morphology, it can be divided into peg-shaped conical supernumerary teeth, which are either conical or triangular in shape of crown, and complete root formation that can be seen. They usually found in between two maxillary central incisors. They remain unerupted, and they might remain unerupted and also cause midline diastema or cause rotation of incisor. The second type being barrel-shaped or tuberculate supernumerary teeth. The tuberculate supernumerary teeth is generally barrel-shaped, and the crown consists of multiple tubercles. It may be invaginated. Tuberculate type either have incomplete or absent root formation. They are generally larger than conical supernumerary teeth. Then coming to supplemental teeth. Supplemental teeth are nothing but this kind of supernumerary teeth resemble the normal teeth. They form at the end of the tooth series. The most common supplemental teeth include permanent maxillary lateral incisors, although supplemental premolar and molar also are commonly seen. Odontomes. Odontomes are nothing but benign, disordered overgrowths of mature teeth tissue. They can be compound or complex. Compound odontomes comprise many separate small tooth-like structures. A complex odontome is nothing but a single irregular mass of dental tissue that is present. It has no resemblance to the morphological teeth. So what are the problems that are associated with the supernumerary teeth? That is failure of eruption, displacement or rotation of permanent teeth, crowding, pathology and other complications, incomplete space closure during orthodontic treatment. So the other local factors include missing teeth, that is congenitally missing teeth is by far the most common, even common than the supernumerary teeth, and they can occur in either of the jaws. Congenital absence of teeth is referred as hypodontia if some of the teeth are missing. If all the teeth are missing, it is called as anodontia. If 6 or more permanent teeth are missing, it's called as oligodontia. Hypodontia usually affects the last teeth of the series, that is such as third molars, upper laterals or second premolars. Coming to anomalies in teeth size, there should be a harmony in between two sides of the arch, the length and also the maxillary mandibular arch sizes to have a normal occlusion. Anomalies in teeth size can be two types, that is microdontia or macrodontia. Macrodontia is nothing but the tooth size is larger than the normal. So what is the frequency is in permanent dentition, 11% macrodontia can be seen. Affect most oftenly it's the upper central incisors and second premolars, and lower third molars are affected. Microdontia is nothing but smaller than the normal teeth size. It's important to note that the teeth affected are usually the ones that are most commonly congenitally absent. It is most commonly affected with syndromes like Down syndrome. Anomalies in teeth shape. The presence of peg-shaped maxillary lateral incisors is most oftenly also associated with spacing and migration of teeth. Abnormally large cingulum on maxillary incisors is also very common. Additional lingual cusp of maxillary second premolar, which increases the distal dimension of the teeth. Fusion is nothing but fused teeth that are present as two separate tooth germs fused into one single teeth. Gemination is division of a single tooth germ into two separate structures. In congenital syphilis, in which Hutchinson's incisors and Mulberry molars can also be seen. Any dilacerations or dense evaginatus can also be seen. Abnormal labial frenum. Abnormalities of maxillary labial frenum are quite often associated with maxillary midline spacing. Prior to the teeth, the maxillary labial frenum is attached to the alveolar bone, and some fibers can also go over lingually to the incisal papilla. Midline diastema can occur due to a number of causes that include presence of unerupted mesoodons, abnormalities in tooth size and number. Premature loss of deciduous teeth. It occurs mainly due to factors such as caries, trauma, endocrinal disturbances such as hypothyroidism, metabolic disturbances such as hypophosphatasia, prolonged retention of deciduous teeth such as due to absence of underlying permanent teeth, endocrinal disturbances such as hypothyroidism or hyperthyroidism, ankylosed deciduous teeth that have failed to resorb, malposition of erupting permanent teeth, delayed eruption of permanent teeth. Early loss of primary tooth might cause formation of bony crypt over the succedinous teeth, which might lead to delayed eruption of the permanent teeth. Presence of supernumerary teeth that block out the permanent teeth. Congenital absence of the permanent teeth, presence of odontomas or other tumors, other cysts or tumors that might prevent permanent tooth from erupting. Presence of any heavy mucosal barrier that might also prevent eruption of permanent teeth. Then coming to the other factor, that is abnormal eruptive path. This is generally a secondary manifestation of a primary problem. The causes of abnormal eruptive path can be physical barriers such as crowding due to arch length deficiency, supernumerary teeth, retained deciduous teeth, presence of root fragments, any bony barrier, mucosal barrier or any impacted teeth. The other causes may be trauma, any mechanical influences such as orthodontic treatment, pathological conditions such as coronal crypts, or any idiopathic cause such as ectopic eruptions. Ankylosis. Ankylosis is in any accidents or trauma infections in congenital disorders such as cleidocranial dysostosis. Sorry, I'll go again. Accidents or trauma infections in congenital disorders like cleidocranial dysostosis predisposed to ankylosis of the teeth. Then coming to dental caries, any substantial reduction in arch strength can be expected if several adjacent teeth that are involved by proximal caries are left and are unrestored. Improper dental restorations. Any improper dental restorations may predispose to malocclusion. Over-contoured occlusal restorations, they cause premature contacts to the which cause functional shift in the mandible during jaw closure. Under-contoured occlusal restorations, what they do is they cause the opposing dentition to supraerupt. Proximal restorations that are under-contoured, they result in loss of arch due to drifting of adjacent teeth to occupy the space. Thank you.